Good afternoon. I'm Csaba Varga, PhD student in the orthopedic department of Semmelweis University. And my PhD program is about the indications in foot surgery, especially in the surgery of flat foot and ankle replacement. I would like to achieve that the international results in foot surgery are widely used in the clinical practice in Hungary as well. With our scientific work, we would like to contribute to the development of the professional guidelines. The first part of our work is the investigation, the role of body mass index in total ankle replacement, and the other part of our work is the comparison of the operative techniques in the treatment of adult flat foot deformity. Let's see our first project. This is the investigating the safety of total ankle arthroplasty in relation with body mass index. A little bit about the background. The number of total ankle arthroplasty has increased quickly in the last 20 years, as the figure shows. And as the amount of ankle arthroplasty raises, the complication rate is increasing. That's why it is crucially important to know the risk factors of the complications. The most common and important complications can be seen on the slide, and there are proved prognostic factors which can lead to these complications, such as diabetes, smoking, arteriosclerosis. But what about BMI? In a clinical practice, the body weight is a crucial selection criteria because the negative effect of BMI to the outcomes of hip and knee arthroplasty is proved. But in case of ankle arthroplasty, the prognostic rule of BMI is still unclear. This example shows that two scientific articles has appeared in the same year in this field. Some of them shows the negative effect of BMI, and the other says it has no effect on the outcomes of ankle arthroplasty. So in our orthopedic profession, high BMI is a source of many problems, such as arthritis, enthesopathies, overloading joints, muscles, and tendons. So our aim to clarify the role of BMI as a risk factor for complications and revision rate after total ankle arthroplasty. Our clinical question is the same. Does BMI increase the rate of complications and revisions after an ankle arthroplasty procedure? We have collected the articles from 3 scientific databases, and after the systematic selection, we have 22 articles to make the statistical analysis. This is our first forest plot about the revision rate of total ankle arthroplasty, divided the patients into under and above 30 of BMI groups. We have involved nearly 9,000 patients in the analysis. We have found that approximately 1.5 times higher rate of revisions in the obese group from the raw data. It can be seen on the bottom of the slide. And the random effects model shows the same difference between the groups with the low heterogeneity between the populations, and we have a narrow confidential interval, and it means our difference is significant, and it means that an obese patient has approximately 1.5 times better chance to undergo on a revision procedure as an obese patient after primary total ankle arthroplasty. The next forest plot is about the complications. We have detected nearly twice higher rate of complications in the obese group. It can be seen on the bottom on the slide, but because of the large heterogeneity between the populations, we could not prove this difference. The confidential interval contains the number 1, and it means the difference is not significant. We got the same result about the local complications. We have detected nearly twice higher rate of local complications as well, but we have not enough articles to achieve the appropriate power of the analysis, so the result is not significant as well. Strengths of our work is we are investigating different aspects of the role of body mass index in ankle arthroplasty. Ours is the first quantitative analysis in this field, and we have involved large amount of patients, but our investigation has limitations as well. So we have a high statistical heterogeneity in case of complications between the populations, and the complication definitions are different and they are overlapping. And we could summarize only the under and above 30 of BMI groups. The BMI is often part of metabolic syndrome, and that's why it's associated with other confounding risk factors, which can influence the results, our results. So as a conclusion, we can say that revision rate is higher in obese patients after the primary total ankle arthroplasty. The clinical implication is to predict and avoid the complications, which can influence the cost of the treatment. And based on this analysis, we have to consider the change, the treatment protocol in case of obese patients. The clinical implication is the recommendation. We recommend to describe the type of complications and the cause of the revisions in the further studies. The second part of our work is the comparison of the operative treatments of adult flatfoot in different stages. So about the background, the adult acquired flatfoot deformity affects nearly 15% of the adult population, and from this, 7 to 15% of these patients needs to be treated because of the symptoms. But the guideline allows multiple choice of operative treatments. This is the flow chart, and this is the guideline about the surgical treatment of adult flatfoot. It can be seen that one intervention is involved in several stages, and there are many methods to choose from within a single stage. So the guideline only provides options per stages, but the type of the surgery is currently selected based on the individual decision and the experience of the surgeon. That's why our aim to compare the effectiveness of the different surgical techniques in this field. Our question is which surgical technique is the most effective, and the clinical implication will be we will choose the most effective technique in each stages. We have collected the articles from 3 scientific databases, and we have found 4,143 articles, and after the systematic selection we have 54 articles to make the statistical analysis, and this is the state of our second project now. Again, an overview. The first one we would like to finish in May, and the second one in July. As I mentioned, our orthopedic profession needs simple rules. That's why I would like to close my presentation with a quote of an American computer scientist. Simplicity is the shortest way to the solution. Thank you for your attention.
Congratulations on your presentation. I would like to ask, what can you offer those patients who are not appropriate for total ankle arthroplasty, for example, because of high BMI?
Yes, thank you for the question. Previously, we have used another operative techniques before the ankle arthroplasty. This was the tibiotalar arthrodesis. This is a safer procedure as the ankle arthroplasty because it has a lower complication rate as the other, but the ankle arthroplasty has a little bit higher function score, and that's why it's crucially important to make this decision which patients are appropriate to receive this type of operation.
It was nice, congratulations. You mentioned earlier that the BMI is definitely affecting the hips and knees. Am I right?
Yes.
And you were not able to prove that the high BMI is significantly causing the complications. In spite of that, the revision rate is much higher than for the knee and for the hip. Why do you think? I'm almost absolutely sure that the BMI is really significant. How to prove that? Probably more data is needed.
Yes, we should have more data about it, because I think we are at the beginning and there will be not enough from these articles. But my opinion is that the BMI influences and make high revision rate. To prove this fact, we have made this investigation. And I think this analysis shows that because it was a significant difference, so this result has not received until now nobody, according to the scientific literature. So most of the articles were on the opinion, so not on the same opinion. Some of them said that it has no effect to the outcomes, and some of the articles try to prove the negative effect of BMI on the revision rate. Yeah.
But can we go back to your adverse effects slide? Because in the dentistry group, actually, we saw something similar.
Go back to the plot. Yes. Yeah. About the BMI. Yes.
I mean,
on this sheet.
But, wait. I understand, and very good. But even But I think this represents a problem. I mean, we had something very similar in the dentistry group, actually, when there was some kind of treatments. And the sample size was just as misbalanced as here. So you have the very first study, which actually pulls the whole thing to the left. I mean, that's a small kind of sample number. While in the last one, which would be for actually showing that this is an important thing, that's a huge study. And then when you use the random effect model, I mean, we talked about this against the statistician, how to solve this. And this is maybe not the final word, because they also work on this. Then maybe the random effect model is not the optimal one, since what it does, actually, it equals the different studies, small size and big size and so. And therefore, actually, some of the messages, I mean, just overlap by this kind of, I would say that statistical bias. I mean, no statistician in the room, so maybe I can say this. But so to me, I mean, this has a message. I mean, if you do a study, I don't know how good the quality of that, but I mean, 4,000 people were followed, or something like that. Actually, altogether, 5,500 or so. And so that's a reasonable big size of study. So probably when they did it, I mean, even the kind of heterogeneities, I would say that just taken off by the large size. While all the other ones were relatively small size. And if this is a rare event, then the rare event actually comes up randomly. So it may show up actually statistically only in the large star study. But then the meta-analysis may covers this. Or I mean, if anybody else, even the SMSs, could tell something about this. But this is a kind of open question. So when you present this in your paper, I mean, maybe this is not the final word, even within the discussions. And when you present this data, that you can say that there is, I mean, just like what you said, I mean, there is a very good chance that there is an effect here. But in the individual studies, just because of the small sample size,
yes,
I mean, that actually covers the real difference.
Yes.
So very good work anyway.
We think so. It's maybe because of the low sample size, and we think perhaps it's because of the different types of complications. So every articles use other types of complications, and the other problem is they are overlapping.
Yes, please.
Congratulations on your presentation and on the progress. I don't know the answer to this question, although I'm on SMS. What were the reasons why the patients came for a reevaluation or for a revision? And can these reasons raise awareness for the possible problems that could appear with obese patients versus below 30 BMI, although, so this is the only significant result that you have, the revision rates. Is there the causes are mentioned in the articles, and could this give a hint on what the surgeons should be aware, why the patients come back?
Yes, it's a very difficult question. So we are surgeons, and we are not interested in the relationship between the cause of ankle arthroplasty and the high body weight. So we are interested in the complications and the high BMI or other risk factors, because the real question for us is, should we operate that individual person or not? And because we have other chance to choose, that's why is a crucial question, and this have to decide. This we have to decide at the moment as the patients come into the room and ask for him and complains about her painful leg, and based on these results we have made this decision.
Thank you. I'm a clinician, so I'm not a surgeon. But...
Looking at this number, under 30 is 6, over 30 is 12. You have to find a method to prove that it is significant.
Okay, just the last comment. Professor Bucci and myself are the national representatives for Hungary in there's an international work group in the periprosthetic joint infection. And we were not able to prove that BMI plays a very important role in periprosthetic joint infection, and neither were we able to prove that a bariatric surgery that reduces your body weight will decrease the rate of periprosthetic joint infection. We all know that it is not true. Unfortunately, we cannot prove it, so be very careful with the evidences. I think this is the main issue. Thank you very much, Csaba.
Thank you very much.